Oh, what's happening? Aha! Whoa! There we are. We are live. Dr. Rosen, can you hear me?
Yes, I can.
Okay, Dr. Mattay. Sorry. Oh my Lord. Well, this is why we log on early. So, hello everybody. This is Dr. Linda of the VBF. You're probably all there waiting for us to get on. I'm just waiting to see us on here. I apologize, technical difficulty. Are you guys seeing it on there? Is she seeing it on our Facebook page? Because I'm not seeing it on our Facebook page. Oh, it says we're live. So I'm just looking for us to show up so I see the questions. Okay, it says we're live. I'm on our page and I'm still trying to see you two guys so I can see. Can someone let us know? Yep, there's people on, but of course I can't see the questions. I'm trying to get it on my phone. Thank you, Dr. Rosen, for your patience, for waiting for me to get this
I'm
going.
very patient. Dr. Mattay is freaking out.
And welcome, Dr. Mattay, to your first VBF Facebook Live.
Thank you.
Usually, if I'm there in person, we just click the button and we go live, and it's no big deal. But when you're streaming from another platform, it's difficult. I know we're live. Are we live on oh my God, that's the problem. We're live on my personal page. That's why. Hold on. Let me switch it. Okay. Whew. So we were live on my personal page. Now we're live on the VBF page, which is why I wasn't seeing it. Oh my Lord. Okay. Now it should show us, and I'm not seeing us. But there's 7 people on, and it's on the we're on the VBF page. Yes. Okay. Can somebody, I see people on, but I'm not seeing any comments, and I'm not seeing it streaming on our Facebook page. If you are on,
You seeing it
please.
on the page live?
Yellie's saying she's seeing it live.
Who is saying it?
Yellie.
Yelly is here.
Okay, I'm not, is she on our VBF page?
Yes.
Okay, thank you. So I'm not seeing it on our Facebook page, but I'm gonna log out. And then I'm gonna log back in, and maybe that will, and usually that triggers it to let me see it.
So you can't see the questions, Linda?
No, I can't even see us on it. Are you seeing any questions?
No?
Is she seeing any?
I don't
Because,
see any questions at the moment. Kiana checking in. Welcome to the BBF team, Dr. Rosen, Dr. Mattay. We're now live. We are seeing you, Jeanette Halibut, your patient.
Great.
oh, that's great. Well, I'm logging off my phone and restarting it so that I can see the questions. I can also get my iPad. I'll probably see them easier on my iPad since my phone's not working. But Dr. Mattay or Dr. Rosen, would you please introduce Dr. Mattay and tell us the exciting news about what I'm calling the head to toe center? The AVM center is the head to toe center. So would you like to introduce him to everyone and tell us more about what you guys are doing together, what kind of new treatments and modalities?
Yeah, so we're thrilled to have Dr. Mattay join us. He trained at University of Pennsylvania and UCSF in neurointervention and neuroendovascular surgery. So he's got a tremendous experience in both intracranial and head and neck vascular anomalies. And that was one area where we had to refer a lot of patients out that had head and neck lesions. And we will now be able to accommodate all those people with his expertise.
Oh, that's wonderful.
We'll be working together.
That's wonderful. Welcome, Dr. Mattay.
Thank you. Thanks for having me.
I'm very excited. Also, Dr. Rosen, just for the sake of all the patients and the people watching, they're on now. They're all saying they see us. Thank you. Let us know where you're from. And your questions for Dr. Rosen and Dr. Mattay and or myself. We just came off of our annual conference and clinic. Unfortunately, Dr. Mattay couldn't be there because his sister was getting married in Italy, which is really cool.
Yeah.
And I'm sure it was a beautiful event. So yeah, so everybody's logging in now and we are live. And we can take your questions now. So hi, Dawn. Hi, Cus. There's Batul is on, Dr. Rosen. So
Okay.
we know that Dr. Rosen's your favorite. So we have him on here for you,
Linda,
Batul.
if I could interrupt for 1 second,
Yep.
I'd rather let Dr. Mattay give a little brief summary of what his areas of expertise are, and it's a lot of it is things I never even heard of before he came here.
I
So
know. I love it.
yeah,
Let's
so it's
hear
quite
it.
exciting. So let me turn it over to him for a bit,
Yes.
and then we'll take the questions.
Thanks, Dr. Rosen. And so, yeah, I am a neurointerventional radiologist. And my expertise, specifically for this Facebook Live event, I'm very interested in head to toe vascular anomalies. I've had the experience of doing a lot with them in my training, and now also with Bob Rosen being my mentor. It's been great. Specifically, interested in venous lymphatic malformations of the head and neck, lip region, orbital region. We have a lot of new technology available to us here at Lenox Hill, which allows us to treat these lesions from kids to adults. Outside of the vascular birth realm, I also am particularly interested in cerebrovascular venous disease, specifically the symptom of pulsatile tinnitus, which is like a rhythmic heartbeat in people's ears, and also interested in interventional neuro-oncology and head and neck cancer.
And also, like, what about intracranial AVMs?
Absolutely. And that
And
falls into
that's been a big gap for our people.
yes, absolutely. And so that falls into the realm of neurointerventional radiology, and I have a lot of experience with that.
And extracranial facial AVMs.
Yes.
Awesome. Again, that's, a big need that we have here in the US. And also, you told me that you are also credentialed in HIFU, high intensity focused ultrasound.
Correct. I have experience doing high intensity focused ultrasound intracranially for symptoms like essential tremor and tremor related to Parkinson's disease. Where I'm in the process of trying to build a center here at Lenox and within the Northwell system. But there shows to be a lot of promise for this technology also in vascular anomalies. And so, we hope to eventually work on that.
I'm looking forward to that because ever since I saw it, I said, ooh, venous malformations, especially like the intermuscular ones, where
Right.
right where your target is.
Right.
So very excited. Okay, everybody. So we can start taking your questions. We have quite a few people on. I guess they're just all listening. But Emma, Albert, Lynn, Dawn Marie, Chris, Cree, Vanessa, please ask Colette, ask Dawn, please. We're ready to take your questions. And also both Dr. Rosen and Dr. Mattay have been very good about answering patient emails and inquiries. So Kiana, I believe, is on. And if you can share, Kiana, either the emails or the VBF Ask the Expert links so that people can directly contact them, that would be great to share that on here as they begin to ask their questions. So we're ready to take your questions. The last one I see is Colette Patterson is watching. Is that person that's in there with you seeing that one as well?
Yeah, you're seeing Colette Patterson.
No, I don't see that.
She doesn't see that.
What's the last post that you see?
I see a question from Lynn Char.
What is it?
Do you have experience with CMTC? Do you recommend routine MRI with contrast or CMTC?
That's cutis marmorata telangiectasia congenita, CMTC.
Okay. Yeah, we usually do not treat those specifically. They're usually just monitored. Some people are using laser with moderate effectiveness. But yeah, I don't think anything much has changed in the last 2 or 3 years.
Oh, good. Now I can see the questions come in. Yeah, I mean, typically when we see them, we ask them to get imaging done and a laser. That's like, because these fade out, right, Dr. Rosen? A lot
Yeah,
of them
the
fade
tendency
out.
is for them to be outgrown over a
Yeah.
period of years.
Okay, so thank you for that question, Lynn. And it says, oh, she said also, would a vibration plate help build muscle and help with blood flow with this condition? Would a red light, infrared light help with that circulation or PEMF? That's interesting. I've never even heard of that. What is a vibration plate?
You got me. That's a new one on me. But I would say, and it's a common misconception among patients or parents of patients, that a lot of these vascular malformations have some adverse effect on the overall body circulation or circulation in a limb. And it's rarely the case, certainly not with CMTC. It wouldn't be affecting the overall circulation, and there wouldn't be any long-term worry about a problem with leg not getting enough arterial supply. It usually doesn't affect that at all.
It shouldn't affect the muscles either, right?
Yeah, it shouldn't really affect the muscles either, for that matter. And I mean, sometimes you can have soft tissue issues related to some of these malformations that are kind of, what they used to say was true, unrelated. The two things can go together, but one's not causing the other. So if there's some muscle atrophy or, underdevelopment, it wouldn't be directly caused by the CMTC. And I can't see something like a vibration helping it, but certainly would be harmless, I would assume.
In my mind, when she says that, I guess I'm thinking of HIFU, right?
Well, it's totally different. Yeah, it's totally different technology. So,
yeah. But that's in my mind, I'm thinking of vibration plate and HIFU being sonic,
well, yeah, I mean, they both involve sound or vibration, but I don't think there would be any link between them.
So we are still taking questions. Is she seeing another one? Because I'm not seeing them.
Yes, the next question from Dawn Marie is that, hi there, will your facility also assist in vascular birthmark anomalies in the limbs, legs, and feet and hip areas?
Absolutely.
Yes, I mean, that's what we've been doing here for 45 years, actually. So, yes, we do a lot of trunk, abdomen, chest, limbs, including hands and feet. And really what we're adding is Dr. Mattay's exercise and experience and expertise in head and neck and intracranial disease.
And also, don't you handle truncal and also what about GI? Don't you handle some in there as well?
Yeah, we do internal problems as well, and as far as aneurysms, malformations. Not that common, but we do see them and we do treat them.
So Lynn that asked the question before asked another question. So her daughter has the CMTC, and what she was saying is she has atrophy of the entire leg. And we do see that sometimes in KTS, right? It's like I don't know, I call it like a Steele syndrome where the leg is actually smaller rather than overgrown.
Yeah, although it can be either. We see overgrowth and undergrowth with KT, and you have to wonder if there's underdevelopment of a limb, whether there's something more than just CMTC going on. And I don't know who she's seen in terms of somebody with expertise in these things, but it may be worth getting some studies, including genetic studies, and see if there's some genetic defect that could be linking all these things together.
That
It may
makes
be a
sense.
form of KT, actually, rather than just CMTC.
Makes sense. Meg Donnelly says, have you seen trigeminal nerve pain with patients with large facial AVMs? And if so, are there treatments?
Yeah, I think that certainly, I mean, it would first, I think we would need to figure out, is it a low flow or a high flow, AVM? Is it a venous malformation or not? But either of those things, the inflammation surrounding a low flow, venous malformation certainly could cause irritation of the trigeminal nerve, and therefore cause trigeminal nerve pain. Additionally, especially if it's in the location where the trigeminal nerve runs. Additionally, if it's a high flow AVM, even just the pulsations next to a nerve could be irritating. And so depending on what it is, I think we could map out certain treatment options and try to give them the best result.
That sounds great. Yones Arif says, and I can answer this, I have a birthmark wine stain and I want urgent laser if possible. Yones, you can go on our website at birthmark.org up at the top where it says find a doctor, look in your country or the regions surrounding your country, and you'll see experts and they list whether they are a laser expert or an interventional radiologist or a surgeon. So if you go on there, because I don't know where you're from, but if you have anything other than a basic port wine, like if there's any overgrowth or if it's on an extremity, then that's more questions for our team that's here today. But if it's just a basic port wine stain, you can get that information on our website. So hi Dawn, hi Melanie, hi Jeanette. Let us all know where you're from, and this is a good time to ask your questions because you have these experts here today talking about treating extremity and now head to toe, intracranial and extracranial AVMs, which are I call them arteriovenous monsters because boy, they sure can be. Especially when you have a patient like we were talking about before that has multiple nitises. She had 3 nitises. So, you kill one beast and you got 2 other heads that pop up, like that line from the Marvel universe, chop off one head, 2 more will appear. And that's what it's like with these AVMs that have a multiple nidus. So I don't know if you've treated any that are like that. Have you treated any that have multiple nituses?
I mean, either that or, diffuse nituses all around the jaw, have had experience with that. In certain scenarios, it's, palliative treatment. In other ones, it's, it causes bleeding. So we target the area that's bleeding. Oftentimes we do it, preoperatively. Sometimes these patients with large facial and jaw AVMs have a lot of teeth and gum issues and need teeth pulled. And in those scenarios, they need some preoperative embolization to make sure that the patient, that it's a safe teeth pulling. And so, we deal with all of those.
Interesting.
One thing I would just add is that it's commonly lumped together. People call all these things AVMs. And actually in practice, and even a place like this that specializes in vascular anomalies, 9 out of 10 of them are low flow venous malformations with no arterial involvement. And they're quite different animals and they behave differently and the treatment is different. So it can make a difference in terms of what you read online, and the doctors that you consult may tell you things that is true of one of these kinds of conditions and not true of the other kind. So knowledge is powerful in this area.
Yeah, and that study out of the Boston group that said 65% of the patients that go to them, that means they've been referred to them by somebody that knows enough to know that they handle them. 65% are misdiagnosed when they get them. 65%.
Yeah, and the other, the other common offender was them calling everything a hemangioma.
Right.
So, I mean, for 40 years, every vascular lesion, especially in a young patient, was called a hemangioma, and then parents would look up, hemangioma, and they would say, well, the child's going to outgrow it by age or whatever, and it never went away. It just kept getting bigger. So that was actually a vascular malformation. And again, there's still splitters and lumpers, but that's a kind of a fundamental mistake, is calling any of these things a hemangioma that's not the infantile lesion.
What is the best imaging study to get so that you're definitive in the diagnosis?
Well, I mean, in terms of differentiating those things, or even high flow versus low flow, ultrasound in the office gives you a quick and easy and non-invasive way to determine whether it's high flow or low flow. And then if you need more detailed imaging, say prior to treatment, MRI is probably the gold standard in terms of seeing the anatomy, seeing the surrounding tissues, seeing flow patterns, things like that.
Do you do the ultrasound right at your center?
Yeah, we do. Virtually every patient that comes in, we do an ultrasound in the office at the time of the visit. And that's kind of a fundamental part of the evaluation, and it's easy to do. And yeah, you certainly can narrow down what's going on with a quick ultrasound.
Yeah, that's one of the things that I'm actually pushing for, and I would love to see ISFA adopt, I don't know if they will, is to ultrasound all vascular lesions before you treat, because as you know, we've been at every conference, we've caught 2 or 3 port wine stains that have underlying AVMs, and you don't want to laser those. It's like poking the bear. They call them CM AVMs now, capillary malformation dash arterial venous malformation. But Marty Mims said there's no such thing. He said it's an AVM stain. It's not a capillary stain. There's no capillaries in it. It lights up like an AVM. Even the little patch on the skin lights up like an AVM. And then what's underneath lights up like an AVM. So I'm really hoping that this will become standard at laser centers and any vascular anomaly centers, but it's not, because a lot of the patients write to me and say, how do we get an ultrasound? Our doctor won't give us an ultrasound.
Well, even, at the clinic last week, I think you mentioned the little boy that came in with like a lemon-sized mass on his foot. And it was called a variety of different things, including an AVM and a venous malformation. And you put an ultrasound probe, which we did in that clinic. In 2 seconds, you could see it's solid tissue and it's hypervascular, and it was a congenital hemangioma. So yeah, it's extremely valuable.
And so important, because there's a huge difference between telling somebody it's a congenital hemangioma, which can be excised and then they go on their merry way, versus an AVM, which is really no cure and tricky management, right? So there's a huge difference in getting an accurate diagnosis, and any of these vascular lesions, any of them really should have an ultrasound before any kind of treatment. And we're big on this, and I would love to see us have not to put you on the spot, but an annual free ultrasound clinic at your center. Just, because so many people don't have access to this. I don't know if that's possible, but
Yeah, actually, two of our ultrasound techs from the vascular lab here were at the clinic your free clinic this past weekend, and they've been studying our patients for many years, so they're actually quite sophisticated at studying them and looking at all the pertinent factors in terms of flow and extent and how the surrounding tissues are affected. Because ultrasound, as most of you probably know, is a very operator-dependent test. Somebody who has no idea what they're looking for can do an ultrasound and come up with a diagnosis. They can be completely incorrect, because it's how you do the study, it's all the different modalities you use, and the experience you have. So it's not anybody could just do these ultrasounds and come up with an accurate diagnosis.
So another one, okay, here are a lot of questions. Okay, Emma Albert, not a question, but just wanted to say hi to Dr. Rosen on my way to class, finishing my master's in public health in Boston, doing work in rare disease research and federal policy, much of it inspired by growing up with you as my doctor. So thank you. Excited by all the updates at Lenox Hill.
That's great.
Thank you, Emma. And she's one of my all-time, I'm not just saying that because she's on this call, but one of my all-time favorite patients, who's been an inspiration to lots of children with these conditions, and the things that she's been able to do and excel at is remarkable. We sit there with our mouth open sometimes, and sports and medical research and all kinds of things. So
and that's why she's one of our favorite global ambassadors.
Yeah,
because she is the hope for so many parents, isn't she,
Yeah.
of these children? She's going for her master's degree. She's doing public policy. She's helping rare disease. Way to go. Jeanette says, have you found patients with Parks-Weber developing low blood pressure? Recently, my pressure is in the low 80s over 40s. They have run the typical tests and found no cause. They now are wondering if it could be related to the Parks-Weber.
this is, I'm sorry, is this,
This is a new question
no,
from
who's asking the question?
Jeanette Hallibuck.
No, yeah, she's a long time patient of ours.
Okay.
And she has a high flow AVM in the foot, which has caused intermittent problems with skin breakdown over the years. In terms of hypotension or low blood pressure, I can't see where there would be any relationship to the malformation. So no, I don't think that's the cause.
It's
One of the
interesting.
questions is it symptomatic or is it just something they found on a routine physical?
Interesting. So Lynn Char says we are at 6 kids in Toronto. They ruled out KTS with a clinical evaluation. They said undergrowth is common with CMTC, which could be.
Yeah, can happen. Yeah.
So Dawn says, when children become of age, making the transition to adult care, will your facility serve young, youth, and adults as well? I remember my son having pain, cramping in the leg, the birthmark could not be removed, and he was prone to clots. Is that something common?
It certainly can happen. And we do, obviously, since we follow kids, many of them for many years from infancy to adulthood, we don't cut things off at a certain age or say that's a pediatric problem. We don't see that. We kind of give them a lifetime contract, so to speak, that we will continue to follow them. And we have other specialists, such as the pediatric orthopedic surgeon that we work with. Dr. Amaral is theoretically just a pediatric orthopedic surgeon, but he also follows these people for many years as they grow into adulthood, and he's been extremely valuable in helping us take care of them.
That's great to know. Dawn Marie says, when children become of age, oh no, that we already answered that one. Lauren says, hi doctors, Lauren from Tennessee. Any experience with treating tufted angioma without KMP, so that's Kasabach-Merritt phenomenon, and without KMS, beyond sirolimus or vincristine? My child is looking to discontinue the sirolimus due to his malformation, and I'm worried if it flares up after continuing his medication, that our only real option is to go back on sirolimus since it's in his groin. Not a horrible option, but there are a lot of unknowns with him being on immunosuppressant for the rest of his life. This is one, and I want to tell you both about this because I'm going to connect you with the new CEO of this company, Proterra, which has now licensed, it's called, it used to be OK432. Remember that, Dr. Rosen, the
Yeah, it was
streptococca?
from Japan originally. Yeah.
Right, right.
Mhm.
And now it's Picibanil. And they own it. And they were at the conference. I was trying to have them meet you because they're now treating lymphatic malformations quite successfully with this, doing like a direct stick puncture with it, with the Picibanil. So I'd like to have them, I'm gonna do an introduction with you, but I mean,
Actually,
we need.
one of the things in the question that I wasn't quite sure I understood is that he was on sirolimus and stopped because of his tufted angioma.
I think they just were.
Well, she says, any experience with treating tufted angioma, okay? He's, and then beyond, because he's already been on sirolimus and vincristine, he's looking to discontinue it.
But looking to discontinue. Okay.
Yes.
Yeah, well, that's one of the questions. Actually, I'd be curious to know how effective the treatment has been up till this point, if it's helped. And it's a excellent question that nobody really knows the answers to, which is what's the long-term outlook for drug or anti-angiogenic treatment for these malformations. And there's a fair amount of literature that says even when you respond well, when you stop the drug, you can revert to pre-op status or pre-treatment status or close to it. So yeah, it's one of those areas that I think people don't have a clear-cut answer at this point.
Melanie's on. She's the mom with the little boy with the lesion on the foot, and she says hi and thank you for speaking about our boy. Melanie, I don't know if you were on, but Dr. Rosen said they do have an expert surgeon there on their team that could easily remove this. So if you want to, I think I might have given you Dr. Mattay's email so you could write to him and he'll get you into the network. Because I remember giving you his
So
email.
we'll send. This
Yeah.
is the boy with the.
Yeah, we've got the appropriate people. Yeah, to handle it.
Perfect. All right. Well, let's see. I want to see if there's any more new questions that I've missed because they're coming in and I have to keep logging out and coming back in to see them. Sirolimus has helped shrink it and it is stable. So I guess, I know I'm hearing a lot of adverse side effects. But so Causal has a question. My vascular malformation in my groin bleeds every second day. My gynecologist saw it and didn't advise anything. She says it is an open jumble of vessels oozing blood. How do you like that medical definition, Dr. Rosen? And can any ointment, medicine, laser, cauterization help that can be done here in India? My visa has expired and renewal means a lot of waiting. Hope to see you next year.
One of the questions I would have is it actually blood, or is it a mixture of blood and lymphatic fluid, especially if it's oozing spontaneously and it's in the groin? More typically, that would be lymphatic or mixed venous lymphatic. And you'd really have to get a picture of it, and I'm happy to see anything that you send by email to have a better idea, and also whether any studies have been done as far as ultrasound or MRI to see if it's part of some deeper malformation. In terms of somebody in India, I know some people at Medicity in Delhi who have a fair amount of experience. I've worked there a few times in the past. And I could provide some contact information if you want to get in touch with me directly.
Okay, so that's really good. Great to hear from you, Quassel. I'm sorry you're suffering. So I'm still not seeing if there's been any new ones because they just I have to keep loading them. So about sirolimus.
You see anything?
No,
No?
just
Okay.
mostly comments. No
Okay.
questions.
Okay. So, we're ready. We have like 20 more minutes, people. We'll stay on like a couple extra unless the questions just really drop off. You can go back, everybody that's on, and rewatch this if you're, missed something. Melanie, Lauren, Causal, if you didn't log on when we first started because we were running late. Hi, Carrie. So once again, Dr. Rosen and Dr. Mattay are out of the AVM Center, out of Lenox Hill Hospital. They are interventional radiologists. Their practice treats from head to toe, including intracranial AVMs, which is a very big need ever since the leading expert, Dr. Bernstein, Dr. Aliando Bernstein, has retired. And so I'm very happy to hear that you now have this amazing comprehensive center, like one-stop shopping. So I'm very excited about that at Lenox Hill now. Venous malformations, AVMs, lymphatics, those are probably KTS, Parks Weber, those probably make up the bulk of your vascular anomalies, correct?
Yeah, and by far, numerically, the venous malformations, specifically intramuscular venous malformations, are the number one kind of situation we see. And we probably see easily 10 or 15 new patients a week with new diagnosis of intramuscular venous malformation. And the interesting thing about them is that the vast majority don't have anything visible or palpable. When you see them, they just have pain, especially for activity. And a lot of kids were misdiagnosed in the past and were told they were either a neurotic, or it was an imaginary symptom, or it was a quote growing pain, or some of the other synovial conditions the kids can get. And once you get an MRI, which is the gold standard, it lights up like a light bulb, and there's no question about what the diagnosis is, and they're quite amenable to treatment. So it's something that if you miss the diagnosis, especially in the knee, that's kind of the number one area where we see them, the knee and the foot. But if you miss the diagnosis and they go on for many years, what can happen is you could end up with joint pathology, very much like hemophilia, where they have recurrent bleeds, subclinical. You probably won't realize it's happening, but they ooze blood into the joint space, and blood is very irritating and damaging to cartilage. So over time, you end up with you can have a 16-year-old that has a knee that looks like a 90-year-old just because of the degenerative arthritis. So we try to catch them early and treat them aggressively. And we also, in some cases, work with the orthopedic surgeon who can do arthroscopy and do some of the surface treatments.
Is it a bone erosion from it? The hypervascular?
Well, it's a secondary, the degenerative changes are a secondary phenomenon. The main thing that's happening is what's called hemarthrosis, which means bleeding in the joint. and the bleeding in the joint is well known to cause premature arthritis.
Oh,
So that's a problem. Actually, if I could mention one other, unless you have another outstanding question. No?
no, I have some, but we'll answer them after you're done. Go ahead.
I just wanted to mention, and there's still a lot that we don't know about it, but there are some new technologies that people, I'm sure, have heard about or are interested in, and that includes the high frequency ultrasound that we just spoke about a little bit. There's also something called electrosclerotherapy, which is not the device that you use for this procedure isn't available in the States at this time, but it combines sclerotherapy, meaning you're putting a needle or a probe directly into the low flow malformation and then zapping it. You're actually injecting bleomycin, which is a sclerosing agent, and then zapping it with a very brief high pulse of electrical energy. And in theory, the electrical energy opens up the cell membranes and allows the sclerosin or the bleomycin to have a more dramatic effect in shrinking the malformation. I've seen some cases done in Europe last year, and I don't think I've seen enough to know how big of a leap forward it is in terms of technology. I think in some cases it's clearly been very impressive, and some people swear by it. And we're still waiting for the FDA to approve the device here if they're going to.
Well, Dr. Coletti wanted to speak to you, but he didn't get a chance to. But he's now developing a new, less aggressive, no bleed, where there's no like massive bleeding from the electrosclerotherapy like there is now, but it's a new modified version of it. So I'm going to have to get him to email you and explain it to you, but he was
Sure.
supposed to show it to me and we didn't have time because I'm very anxious to hear about this less invasive way of delivering the sclerosant. So
Yeah, and some people are also actually injecting some of these anti-angiogenic agents like sirolimus or alpelisib into the malformation and then trying to get the anti-angiogenic effect rather than giving it systemically, giving it right into the lesion. And again, I think the jury's still out on whether that's going to make a big difference or not.
Dawn Marie said, thank you for answering me, Dr. Rosen. Do we know the percentage of children or young adults that is affected by clots that have to go on anticoagulants? After my son's 18th surgery with sclerotherapy, he passed from a pulmonary embolism. He was 21. His birthmark would bleed, swelling. He walked with a limp. Just always trying to educate myself on these anomalies.
Well, first of all, sorry for your loss. And the range of vascular malformations, including venous malformations, is huge. You could have little spongy kinds of things that have very small spaces. You could have gigantic venous channels that are just like tortuous hoses with no valves in them that, in theory, present the risk of having clot going to the main circulation, usually in the lung. It's actually much less common than one would think. We probably see it happen once every couple of years. And the question always comes up about anticoagulation and even vena cava filter replacement. We usually don't see the need for that. But it's something that if you are treating some of these patients that have very large caliber anomalous veins that connect directly to the deep venous system, that is can be a setup for pulmonary embolism. So you would be more cautious and you would probably do some maneuvers to control the outflow of those veins, such as coiling them closed or gluing them closed or some way to prevent any clot that you're intentionally causing from traveling. But even though it's called a common complication in the literature, it's actually pretty rare in the world of venous malformations.
Okay, Emma just was saying she had to hop off, but curious if you've had any other patients on everolimus instead of sirolimus, and if so, if they had any benefits, less side effects compared to sirolimus.
I don't know if you have any. No, I mean, there's one of the problems is there's so many drugs being used and so many different regimens being used and pretty much every patient with a vascular anomaly is different. And everybody says that about all kinds of conditions, but vascular anomalies are particularly remarkable for, you could almost say no two are the same. The main two drugs that are being used are sirolimus, as you know, and alpelisib. And alpelisib seems to be more effective. It requires, to get on the protocol now, in this country at least, it requires genetic testing to see if you have a certain genetic abnormality in the affected tissues. That requires a tissue biopsy, gets sent to a special lab. They tell you whether that tissue has the genetic flaw, in which case you could become a candidate for that treatment. Again, I think it's still early days, and I can't say I'm convinced one way or the other of how much it helps.
Thank you for that. Oh, Jeanette Hallibuck wanted to say thank you for answering my questions. I'm in California and would urge anyone who's interested in contacting Dr. Rosen to do so. He is the best. Can't thank him enough for all he has done for me. I don't know if you saw Amanda Pickering's daughter. She was at the conference. She has a pretty complex venous malformation in her mouth, cheek, and lip. She's had 19 treatments and 5 surgeries. It breaks my heart to put her under anesthesia every 3 months. And it seems to be bigger. We've never gone longer than 3 months without any type of treatment. I'm curious of what you could offer to help her without, well, there's no such thing as, being under anesthesia as often as she has. She's only 5.
This is a question for Dr. Mattay, but just 2 things I didn't catch in your or her description. One was the age of the child, and B, why does she keep getting treated? Is it bleeding or something else going on?
Well, I referred her to Gresham Richter, who was doing sclerosing it. I was shocked that she had never had any imaging done. That really kind of surprised me that he's been doing that without imaging. But it's just laser and sclerotherapy, and it is a pretty thick lip venous malformation, and it's in this area like around the cheek and the lip, and it's pretty bulky, so it seems to just bounce right back right within months of her having him do this low-lying, I mean, he's a head and neck surgeon, he's not an interventionalist, but he does just does a little sclerotherapy and laser.
How old is the child?
Oh, I think she's 5 or 6. She's around there.
Yeah, I mean, I think if it's nice to have that history, because if he's doing more, lasers are generally superficial, and then if it's an ENT doctor doing direct injection sclerotherapy, I imagine it also there is rather superficial, and you don't really have an understanding of where the sclerosing is going. And so I understand that it's a lot of surgeries and sclerotherapies this patient has had, but maybe what she needs is one that is more image guided, after formal imaging evaluation with not just an in-office ultrasound, maybe a dedicated ultrasound with an ultrasound tech and an MRI to understand how deep this really goes. And then planning, possibly a sclerotherapy session where we can get to all aspects of the lesion itself. And then beyond that, like if I didn't know this history, I mean, there is also possible medical regimens for large venous malformations that are, sclerotherapy resistant, and that would require some genetic testing. But I do think like it really does require some formalized imaging. And so, Dr. Rosen and I are happy to see this patient.
Yeah, she was at the conference, and I think I asked her, I might have given her your email because I did tell, because I believe also even you I believe Lennox and Northwell, they're pretty good with out of state insurance. I mean, you get people from all over the country, right?
Right.
Yeah.
No, we're fortunate that we have a good staff in the background that's very good at explaining what the procedures are, what the conditions are, why somebody might need, doesn't mean necessarily come here, but why they need specialized treatment in a specialized center. So often the person making those decisions on the insurance side is completely oblivious to what what they're talking about.
Well, and I was concerned about this too, especially because I like Dr. Richter. He's a head and neck surgeon, but it was almost like he was taunting it, in my opinion, because he was not really, he was just, it was superficial sclerosing with a laser. And I don't know if venuses respond like AVMs do, but if you poke around the wrong way, you can actually make it worse. And it's very frustrating because she drives from Tennessee to Arkansas to have this done. And then, a couple months later, it's right back the same, if not bigger, if not bigger.
No,
And
in all fairness, we haven't seen the patient. We don't know the details of
right.
why it was treated. So especially naming a doctor, I wouldn't want to overstep
Right.
what we know in terms
No,
of
no, no.
if this is
He's
wrong
a
or right.
he's a very good doctor, but he's not, I think this needs an interventional radiologist.
Could be.
So Lisa Lally says, I have a vascular malformation in the back and it's around the spine. It has now encroached the epidural space. I have a spinal CSF leak, which complicates things. I'm 52 and concerned about damage within the spinal area. Can you tell me what complications the malformation can cause? As I am very concerned, I currently have no treatment.
I think, in general, again, we would have to have a formal imaging evaluation to understand what exactly this vascular malformation is. Any type of malformation theoretically could cause, especially if it's encroaching into the spinal cord, could cause mass effect on the cord itself, and that can cause all sorts of neurologic issues. From a CSF leak perspective, that also is something that can be treated separate than the vascular malformation. And if they're all related, again, with some formal imaging, we can have a better understanding of how to approach this. Dr. Rosen and I have colleagues here in my department, neurosurgery, who are excellent spine surgeons and vascular surgeons. And so I think we can tackle, all kinds of lesions like this. And it probably, from just the sound of it, would require a combination of our expertise and some of our colleagues' expertise in neurosurgery.
And you could order an imaging study and then have that before she'd have to come from Tennessee, correct?
Absolutely.
That'd be wonderful. Okay, well, Amanda, I think I gave you that, so you can write directly. Lisa says, I have vascular malformations. Okay, that's the woman around the spine. Carrie Fredericks, I'm wondering if there's any medical management prior to embolization. We are now looking at UNC Chapel Hill, but more than willing to come to New York. He's only 4 years old.
Are they, so where was the birthmark on the?
I'm going back to see, they came to the conference.
Mhm.
The woman's grandson has a venous malformation. And they said that they saw Dr. Nasseri and his treatment plan includes needlepoint embolization. I don't remember where it was, but I remember the name. And this she's talking about, so this is your grandson, right, Carrie? So if you can just give us a little bit more history. Meg
What
says,
part of the body was it?
I don't know. She
Oh,
just said,
okay.
I'm wondering if there's any medical management prior to embolization. We're now looking at UNC Chapel Hill, but I don't know. And then she also mentioned above that she had a consult with Nasseri, so I'm assuming it's an extremity lesion. Mostly the ones that we had see him were extremity. There was a few others that went in.
Usually, just as a general comment, since we don't know the details, as a general comment, most people aren't starting with pharmacotherapy or drug treatment before doing focused, direct intervention on the lesions. So it's usually lesions that are so extensive that that specific treatment to the area is not practical, or they've tried it and had multiple sessions and haven't responded. So it's kind of a second tier intervention. So I don't know of any. There are some places that just write prescriptions for sirolimus all the time, and don't really go much beyond that. But I'm not sure that's the right way to go.
And in terms of medical management, also for some of these, I mean, as simplistically as it like, what is it for? What's the symptom? Is it pain? And a lot of places also, if it's just pain and there's concern for clotting in the venous malformation, something as simple as baby aspirin, right? And
Yeah.
compression.
It's one of the common causes
Right.
of symptoms in these low flow lesions is spontaneous clotting that causes pain and inflammation, usually self-limiting. Usually they get better by themselves in a couple of weeks, but aspirin is a good prophylaxis. And they're, with the exception of the kind of sad case that we heard about a minute ago, the clots traveling is quite unusual. So that's usually not a concern.
So for our last question, and then if that woman follows up, I'll mention it. But Meg wants to know, I was a patient for Dr. Berenstein for 30 years, wanted to see if there are any new treatments that have emerged for large AVMs, left face, neck, ear, throat, with osteoma issues as well. Or is it still recommended no treatment unless bleeding?
I mean, I think it's a combination of what seems to be the issue. I mean, obviously, when there is bleeding, we all feel more comfortable embolizing these areas. But if it's cosmetic, if there's other regions that are bothersome to the patient, I think we could evaluate and see if there are components of the AVM that could be reduced in size.
And as far as, has the technology changed over the last 30 years? The catheters and microcatheters have gotten much better. The imaging has gotten much more sophisticated. The embolic agents have gotten better. So the basic principles haven't changed that much, but the actual tools are dramatically better than they were even 5-10 years ago.
So Carrie said the venous malformations on his face near his eye, and Chapel Hill wants him to see an oncologist. So
if it really is a venous malformation, I'm not sure I see, unless it's somebody that does oncology and vascular malformations, it wouldn't be particularly practical to have the child with the malformation be seen by an oncologist. And we, at least 3 or 4 times a year, we see people in New York that had a mass that clearly on imaging was a vascular malformation. Somebody saw a mass and they sent them to Memorial or Sloan Kettering, just because that's where you send a mass in New York a lot of times. But if they've had a good MRI and you make the diagnosis, an oncologist really wouldn't be who you'd be choosing to see, unless there's some specific expertise in that case.
And specifically for the orbital, are they saying it's periorbital or intraorbital? But those things are things we can target precisely for sclerotherapy as well.
well, one question, is there any gene that either parent may carry to have a child born with these types of birthmarks? Are they hereditary? Some, we know about RASA1, right?
Yeah, I mean, there's probably 5 to 10% of them have and that's not to say 10 years from now, when they're much more sophisticated in genetic testing, maybe the majority will have some, nameable genetic defects, but it's not that common in terms of the world of vascular malformations, at least what we know now. They rarely come in with a family history. And except for doing the genetic testing for the possible treatments, overall genetic testing is usually not significant unless they have a family history. We always ask, but they usually don't. There are some exceptions, Osler-Weber-Rondeau syndrome, or HHT, Blue Rober-Bleb syndrome. These can run in families, and they'll bring a child in, and the mother has it, and the uncle has it, and they can have variable types of inheritance.
Alrighty, well, thank you both. It's been a very informative session, and I know that if Kiana has posted information to get a hold of both of you, but also feel free to email me directly at vbfpresident@gmail.com, or you can message me on Facebook, and I will give you Dr. Rosen and or Dr. Mattay's email so that you can follow up with them and go through their office to see them. So thank you both, and hopefully next time the system will be a little bit more cooperative with me. Thank you.
I was saying that the beginning of every event these days is 10 minutes of fiddling with the technology. So
yeah, amen to that. Thank you both.
Pleasure.
Thank you.